on the commonly missed injuries in foot and ankle. In first half, I will be talking on some of the midfoot injuries which are missed commonly. Now, here is a boy who had come from South Africa, and he was a football player, and he was given cast and approved to be a normal X-ray here. And when he came to India, we found that they had missed this talonavicular dislocation. And then to know this particular X-ray, we would have taken the X-ray of the foot with ankle in lateral position. That would have given you the diagnosis. So clinically it was quite apparent, but missed on the X-ray because it's a junctional zone. And invariably he landed up in the midfoot fusion, and it's quite morbid. So when you cover the X-ray, it should be ankle, AP, and lateral with foot. That should be included. So lateral, if you take only the ankle, then so many times midfoot injuries are missed. Another case, this is my own case, and where again there was a obvious dislocation on medial side. This was managed initially by this particular reduction, but it was not accurate. We went ahead, revised it, and did again. It was better, but not the best. Why it was not good on medial side? Because we clearly missed the injury on the lateral side. And we have to always remember, like radiasalna, there are two columns in the midfoot, medial column and lateral column. If there is an obvious injury on medial column, we have to see the lateral column injury as well. So in this case, what was missed here was the lateral column comminution. And if we have to manage these injuries, probably it needs the distraction on lateral side as well. So if this would have been the case where medial dislocation was there, you have to look for the lateral side, and lateral column lengthening would help you to get the reduction on medial side. So do remember something like this, one dynamic pin through and through the calcaneus, while one distractor on lateral side, one distractor on medial side. This may be your intraoperative tool, as well as you may keep it on the post-op period also. But distraction on lateral column will help you to get the reduction on medial side. So this was missed by me on the midfoot injury. Another case where again midfoot is a junctional zone, and that's why these injuries are missed. Again, this was given cast, and patient was walking on it for almost 6 weeks. And when you have to manage this injury, you have to just take X-ray of the normal side if it is confusing, because 26 joints, 26 bones and 33 joints, difficult to just gauge in a busy OPD. So just compare on normal side and see. You can obviously see now the talonavicular dislocation with fracture, and invariably this patient again landed up in huge iliac crest bone graft and midfoot fusion. So the morbidity of these missed injuries is huge, and losing the motion of talonavicular joint is huge. So one has to see that one should not miss day one. So this was the follow-up of same case where we went ahead and did the Chopard's fusion. So the lesson learned, we have to suspect the injury. If in doubt, you can always compare on normal side, and morbidity of missed injuries is huge. Another case, who is a 50-year male, again midfoot injury, and this is a fracture which is involving all the tarsometatarsal joint. Here our this thing should be reading the injury should be to read all the components of injury by aligning the CT scan. Now generally the technicians would align the CT scan like this, But then in midfoot, we have to align the CT scan in this particular manner so that we don't miss the injuries. And this is how one should read, if at all you want to read all the components of the midfoot injury. And here we diagnosed that it was involving all these structures. You see, this particular opening dorsally indicates it is unstable joint. So this is how unstable joint should be read by surgeon himself, because radiologist won't suggest that this is an unstable joint. Inconcentric joint should be read as an unstable joint, and then you won't miss these injuries. After soft tissue settle down, we had to do this many fixations so that you don't miss onto any midfoot injury. Another case of a open wound, and here this open wound was managed by repairing the dorsalis pedis and EHL rupture. But look at this, they obviously missed this particular injury where navicular was absolutely planted to talus, and everything went on well, but 6 weeks later he reported to us with this X-ray. Now after 6 weeks, when navicular is lying plantarwards to the talus, is very difficult to reduce. We went ahead, we did all kind of releases, distraction, and believe me, talus head was hiding the navicular because navicular was plantar to the talar head. We could distract and get the reduction back with these maneuvers. See this is talus head, and navicular is absolutely sitting below the talus head. We had to distract a lot, get the reduction, and this is a long-term follow-up of same patient. This is how we went on to get the healing of this patient. Almost after 4 years, this is a good result. But issue is one should not miss it day one. So this is his function. He is a fire brigade worker and needs good amount of hectic activities. So don't get distracted by clinical scenario where dorsalis pedis was bleeding. So midfoot injuries are uncommon and they are commonly missed. So don't miss on to the midfoot injuries. Coming to the ankle sprain is again a common injury, and so many times you can miss so many injuries in ankle sprain, because a twisting injury, inversion injury will have not only the ligament injuries but some associated diagnosis can be missed. See this, there is a lateral ligament injury, but rather than lateral ligament, this patient had an OCD lesion which was there on the medial dome of talus due to inversion injury. So we had to do arthroscopy and manage this OCD lesion, which was done with the debridement. So many associated injuries can be there with ankle sprains, that is peroneal tendon injuries, or the lateral gutter ossicles, or there may be some anterior process of calcaneus fractures also. So, and along with lateral ligament injury, even you can miss the syndesmotic injuries. See this is the anterior syndesmotic injury which is significant and needs repair. So these injuries can be missed with the ankle sprain. This is anterior calcaneus process fracture, where again it was caused by an inversion injury. Ankle inversion injury can also cause this fifth metatarsal fracture. So you should take the X-ray of the foot along with the ankle. And this is a lateral process talar fracture, you see. This is again a part of inversion injury where lateral process talus fracture is there. So we had to open it and fix it. Now another component of ankle sprain is the avulsion of superficial peroneal retinaculum, which causes this recurrent peroneal dislocation. So in a first go, if you miss this particular part, then you may land up in recurrent peroneal dislocation. So avulsion of the sleeve of the peroneal retinaculum also should be looked for. In this case, we did fibular groove deepening and peroneal tendon stabilization. Last, we may get irritation of the peroneal tendons due to the os trigonum or something like this, osteophytes causing irritation and causing peroneal tendon tears, which were repaired along with the calcaneus slide osteotomies. So it is not only the ankle sprain, but they can cause variety of injuries. Sometimes it is stiff ankle with tarsal coalition that also can cause the lateral ankle impingement. So we should know the diagnosis completely, and not the only ankle sprain should be the diagnosis, and variety of conditions we should keep it in mind before labeling them only as an ankle sprain. Thank you so much. Thank you.